when you look at the document, it makes people feel like they're a burden and that they should do the decent thing and die. I think that that's a dangerous, slippery slope.
There is a perception around the slippery slope concept which actually isn't reality,
My gut feeling is that it's a slippery slope.
There's no slippery slope with death with dignity in Oregon or in the other authorized states.
Those safeguards that begin, they whittle away.
So all in all, I must conclude, no slippery slope for assisted dying.
Safeguards are already failing our most vulnerable.
So since these laws passed, have there been any changes?
Is there such thing as a slippery slope? Assisted suicide has been legal in the United States since Oregon enacted the Death with Dignity Act in 1997. It's also legal in a handful of foreign countries like Canada, Belgium, the Netherlands, and Switzerland. People have warned about the slippery slope of physician-assisted suicide even before it was first legalized. The term slippery slope basically means that once you start down the path of legalized physician-assisted suicide, its use inevitably expands and ultimately harms people for whom it was never intended. In other words, once you're on the slope, it's a slippery slide down.
Homer, we gotta do something. Today he's drinking people's blood. Tomorrow he could be smoking.
Opponents of physician-assisted suicide believe it exists. Supporters don't. So, is the slippery slope of physician-assisted suicide imaginary or a deadly reality? To find out, we'll look at the United States, and we'll do so through the lens of Oregon, since most states follow what's known as the Oregon model. Oregon's landmark legislation is often praised for having precise instructions on who qualifies for approval and for clearly articulating what are often called safeguards or guardrails. These are supposed to keep the law narrow in scope and protect the vulnerable. Here's Kim Callanan, the former president of America's leading assisted suicide advocacy group, Compassion and Choices, describing the core requirements for eligibility.
To be eligible for medical aid in dying, you must be an adult. You must be mentally capable of making an informed healthcare decision. You must be terminally ill with a prognosis of 6 months or less to live, and the dying person is in charge of the process from start to finish. 2 healthcare providers must agree that a person meets the eligibility criteria.
Beyond these 5 that Kim cites, Oregon's bill promised 3 other mandates. You must be an Oregon resident. You have to wait 15 days to protect against rash decisions. And finally, the state has to produce an annual report to provide transparency about the practice. Okay, 8 big safeguards. Let's fast forward almost 30 years and see whether there's a slippery slope or not. Number 1, be an adult. So far, so good. Belgium and the Netherlands have laws to allow minors access to assisted suicide and euthanasia, but so far, the US says adults only. 2, be mentally competent. Not only is Oregon trying to remove this requirement altogether, they never took it seriously to begin with. In America, about half the people diagnosed with cancer will develop depression, and about 10% of the elderly in general suffer from depression. Since these populations are the most likely to apply for physician-assisted suicide, you would think that the model state of Oregon would screen for that, right? Wrong. Last year, less than 1% of patients in Oregon were referred for psychiatric screening. Same with the previous year and the year before that. In fact, Oregon's all-time rate of psychiatric screening is 2.9%. Now, that's Oregon, but what about everywhere else? Well, we don't know. None of the other states collect data on psychiatric screenings, and absolutely nobody reports how many people had their applications for physician-assisted suicide denied. And while we're on the subject of mental competency, one day dementia patients could qualify. Prominent physician-assisted suicide advocates like Thaddeus Pope believe that this is the next logical step. Okay, mental capacity requirements seem to not work. Back to the list. Have a terminal illness with less than 6 months to live. Diabetes, complications from a fall, and even arthritis have all been deemed to meet the terminal illness standard. Everyone knows those aren't terminal diseases. No, these all fall under a nebulous condition of other, a designation that has increased to almost 10% of cases in recent years. And there's another so-called terminal condition that deserves special mention: anorexia.
Our
findings really shocked me. We saw anorexia listed by name as a terminal condition.
Women in 3 states have been approved for physician-assisted suicide solely on the basis of their anorexia. Colorado-based Dr. Jennifer Gaudiani, an advocate for physician-assisted suicide, boasted about this practice in a paper that she wrote. The rationale that Dr. Gaudiani and others use is that some women's anorexia is so severe that their anorexia has become terminal. Now, this concept of terminal anorexia flies in the face of everything medicine knows about eating disorder therapy and prevention. This slippery definition of terminal illness has long been criticized by individuals with disabilities. In many instances, someone with disabilities can be considered de facto terminally ill, since without treatment or assistance, that person could die within 6 months. Okay, requirement number 4, autonomy. You must initiate the process yourself and administer the drugs yourself. Anyone who has worked in a care setting has witnessed the complicated dynamics that play out at a patient's bedside. They know that coercion can come in all sorts of forms, from family members to nursing staff, so it's hard to police how voluntary the initiation of the process is. And you'd think a doctor would need to be present at the most important part of the whole process, the moment of death. But that's not so. There's very little tracking of how patients ingest the drugs. In fact, some states don't even track which patients die from the drugs. They just track people who died, who had been approved for prescriptions. And in Washington state, you now can receive your lethal prescriptions by mail. Drugs with 60 times the killing power of a lethal dose of morphine are now treated like aspirin. And what if you're a family member concerned that the patient didn't self-administer the drugs, or was coerced by a doctor or a hospital into suicide? What recourse do you have? Well, none. Every state offers what's called the good faith provision to protect healthcare workers from being prosecuted for virtually any actions related to the patient's death, so long as they acted in good faith. Who does this protect? The patient or the doctor? Speaking of physicians, requirement number 5, have 2 separate doctors approve your case to provide professional oversight. A physician means doctor, right? Nope. Not in Colorado, Hawaii, and Washington, where physician now encompasses nurse practitioners and physician assistants. In New Mexico, it's always been like that. Delaware's new bill includes advanced nurse practitioners alongside doctors, so this requirement's been really slippery. But like the autonomy requirement that we just discussed, the 2-doctor safeguard was always misleading. Its wording implies that doctors will be there to intervene when a patient is behaving recklessly, showing signs of mental distress, or could benefit from better treatment options. That's the whole point of having a second opinion. But have you heard of doctor shopping?
This man is costing my health plan $5,000 a day. I demand that he die with dignity.
Now look, I'm the doctor here.
Well, I demand a second opinion.
Hi, everybody.
Hi, Dr. Nick.
Doctor shopping allows patients who are denied physician-assisted suicide to find another doctor that will rubber stamp their case, often via telehealth consults. Entire organizations exist for this purpose. And what if one of those doctors doesn't live in your state? Well, Vermont has explicitly allowed for physician-assisted suicide by telehealth. Most assisted suicide advocacy groups enthusiastically support this legislation, so I'd expect to see other states follow suit. So much for physician safeguards. How about number 6, you state resident? Gone. Both Vermont and Oregon now allow non-residents to get physician-assisted suicide approval. For all practical purposes, physician-assisted suicide is now legal nationally, thanks to these states.
Oregon was the first state in the nation to allow medical aid in dying.
Now this year, the state is lifting its residency requirement.
Vermont has become the first state to remove the residency requirement for its assisted suicide law.
What about number 7, a mandatory lengthy waiting period? 7 states where assisted suicide is legal have slashed the waiting period down to 48 hours or scrapped it altogether. You can get a prescription for suicide and end your life on the same day. So the waiting period safeguard hasn't held up. Finally, number 8, annual reporting to provide transparency. Sure, all states produce an annual report. Well, Vermont's is every other year. But the reports themselves are an absolute mess. They feature major data gaps, inconsistent definitions and reporting standards, and a lack of oversight. We've written a research paper that explains all that, which is linked in the description. So of the 8 major safeguards to physician-assisted suicide legislation, 7 of them have been removed or were never enforced to begin with. It all has the feel of a bait-and-switch operation. And this brings us to another part of the slippery slope conversation, because proponents of physician-assisted suicide in the US argue that we're not Canada, where euthanasia is now the 4th leading cause of death, with about 15,000 dying each year. On the contrary, these advocates claim that America has proceeded slowly, cautiously. Using the data from these annual reports, let's stress test that claim. How about deaths nationally? They've increased every single year since 2009. Deaths by state increased every year in virtually every state. The number of prescriptions written, up every year in every state. And it's worth noting that the number of unused prescriptions has increased every year, with over 3,000 unaccounted for since 2020. Where did they go? No one knows. States where it's legal, way up. It's now legal in 13 states, plus Washington, D.C. And 16 other states looked at legalizing it just this past year. Number of complications, things like patients who take the lethal drugs and vomit, experience seizures, regain consciousness. And that's not even including things like severe burning of the throat, which is common. You guessed it, up by 50%. Okay, fine. Sure, the guardrails don't stick around, and sure, the use of physician-assisted suicide has expanded. But what about abuse? Supporters are adamant that not a single documented case of abuse exists.
Well, this law is going to, take out the demented. It's going to take out the disabled. I go, no, it's not. All the data shows that we do not see a slippery slope. We do not see misuse. We do not see elder abuse.
That's not true. Michael Freeland was a 64-year-old man with chronic depression and multiple suicide attempts. When he asked his doctor for physician-assisted suicide, his doctor said a psychiatric consultation wouldn't be necessary. Really? For a guy who was previously suicidal? That's abuse. And remember earlier when we talked about doctor shopping? The very first woman to die from Oregon's physician-assisted suicide law was turned down by 2 separate physicians because both determined that she was chronically depressed. But the physician-assisted suicide advocacy group, Compassionate Choices, stepped in and referred her to a doctor that they knew would approve her. That's abuse. And remember how we pointed out the fluid definition of terminal illnesses? Stephanie Packer, a mother of 4, was denied life-saving treatment for her disability and instead was offered physician-assisted suicide for a $1.20 copay.
My life-extending treatments were not going to be covered anymore, and found out it for $1.20 instead of life-extending treatments.
And in December of this past year, we broke the story of Eileen Meach, a 32-year-old woman with a diagnosed mental disorder who was found dead in a hotel room with an empty bottle of physician-assisted suicide pills by her body. An autopsy confirmed she had no terminal illness. Yet while she struggled to get mental health resources, she easily obtained this poison. That's abuse. Proponents come back to their talking point that not a single case of abuse has been prosecuted in the history of the legalization of this practice. But that's not proof that the law is working. It's proof that it's not. In light of everything we've covered, it's simply impossible to maintain that in the 15,000 deaths from physician-assisted suicide, not a single case of coercion has happened, even once. You can see a 2-step pattern that has emerged in how physician-assisted suicide gets legalized. First, get a foot in the door by passing a law that promises to be narrowly limited and include many safeguards. And second, remove the guardrails or simply ignore them and make physician-assisted suicide as widely accessible as possible. But this isn't merely a pattern, it's a strategy. Behind this strategy is a cunning organization most of you haven't heard of, Compassionate Choices. Formerly known as the Hemlock Society, Compassionate Choices has worked tirelessly for decades to bring physician-assisted suicide to every state and to tear down the guardrails once the law gets passed. Compassionate Choices launched physician-assisted suicide in Oregon in 1997. They got it passed in Washington in 2008. They brought the 2009 court case that decriminalized it in Montana. They brought the court cases in Oregon and Vermont that removed residency requirements. In fact, they've been behind every single legislative battle to legalize physician-assisted suicide, and they've been plaintiffs in almost every court case to expand access. They've even influenced Hollywood films and bragged about it. They've spent nearly $140 million in the past decade alone trying to legalize physician-assisted suicide. There are other groups like Final Exit Network and Death with Dignity and many others, but Compassion and Choices is the mastermind behind physician-assisted suicide. Fortunately, groups are fighting back. The American Medical Association just reaffirmed its strong opposition to physician-assisted suicide, calling it incompatible with the physician's role as healer. And it's telling that the most vocal opponents of physician-assisted suicide are people from disability and minority communities, because they have seen from personal experience how stuff like physician-assisted suicide plays out in real life. These groups have battled relentlessly to protect the vulnerable, and by the way, that's another reason physician-assisted suicide hasn't spread as quickly in America, because many Americans aren't buying what Compassion and Choices is selling. You might wonder, what's at the bottom of the slippery slope? Maybe someone you love is. America's about to get hit by an age wave. The number of people over the age of 65 is set to increase by 50% over the coming decades, while the pool of tax-paying adults is set to decrease during that same period. Medicare and Medicaid, which you most likely will be on one day, both face financial pressures that will only grow over time. The right to die may become a duty to die, first for the poor and disabled, but after that, who knows? I mean, if we're comfortable with suicide-affirming care for the elderly, why bother with suicide prevention for prison inmates, or the depressed, or those struggling with addiction, or the sick who cost insurers and the government thousands of dollars a day? Building a system of life-affirming care at the end of life is a tall order, but it is our only hope. Suicide is never the answer, even when a doctor's helping you. It is always easier to kill a patient than to care for that patient. There's a better way to treat the terminally ill, one that manages pain, provides early access to hospice, supports caregivers, provides respite care and mental health counseling for those who need it, provides support services to the disabled and chronically ill, and honors the right to patient self-determination without promoting suicide-affirming care. In other words, a system of healthcare that helps the patient live gracefully and die peacefully. That is the real compassionate choice facing every American.